Bismillah ar-Rahman ar-Rahim. Hello everyone. My name is Amr Zaky. It's my pleasure to be with you today to talk about acute coronary syndrome. My task today is to give the definition and pathophysiology of acute coronary syndrome as well as the natural history. So let's speak about first ischemic heart disease, which comprises mainly chronic stable angina, unstable angina, and acute coronary syndromes. The definition. What's the definition of acute coronary syndrome? The definition is very important to realize and understand and evaluate the coming lecture. So acute coronary syndrome are clinical presentation. It's a clinical presenting symptom. The main presenting symptom is prolonged angina, what does it mean prolonged? Prolonged means lasting more than 20 minutes, not provoked by exercise and not relieved by rest or sublingual nitrate. And based on ECG, acute coronary syndrome comprises two components, non-STEMI and STEMI. Non-STEMI, the ECG shows the following criteria. Transient ST elevation, not persistent. That means that there is elevation in the ST segment, but after a while on the monitor, we notice that the ST comes down to normal, and doing another ECG, finding that the previous elevation has receded to normal. The second is persistent or transient ST depression, T-wave inversion or flattened T-waves or even normal ECG. So all these components could be inside the non-STEMI diagnosis. While on the other hand, the STEMI, the ECG shows itself by ST segment elevation, mainly due to complete occlusion of one of the coronary arteries. So what's the definition of myocardial infarction? The definition of myocardial infarction, I think all of you knows what's the definition of myocardial infarction. It's cardiomyocyte necrosis in the clinical setting of acute myocardial ischemia. So loss of the blood supply or loss of the oxygen leads to cardiac myocyte necrosis. And cardiac cell death results in elevated cardiac biomarkers. Thus, to confirm acute coronary syndrome from the previous definition, we need the symptom, which is prolonged angina. We need an ECG, which shows either STEMI or non-STEMI, and we need the lab work to show the elevated cardiac enzymes, which is most important is the high sensitivity troponin, either I or T, as well as CK-MB, which has been downgraded a little bit in the recent guidelines of the European Society of Cardiology 2 days ago, which is last September 2020. So a combination of criteria is required to diagnose acute myocardial infarction. First of all, rise and or fall of cardiac biomarkers, specifically high sensitivity troponin, and at least one of the following criteria. Symptoms suggestive of acute ischemia. Number two, new or presumed new ST segment changes or left bundle branch block on the 12-lead ECG. Number three, development of pathological Q waves, also on the ECG. Number four, imaging evidence of new or presumed new loss of viable myocardium or regional wall motion abnormality. So what's this imaging? Preferably and more practically, and it's always available in the emergency department, is the echo. So an echo evidence of loss of myocardium, which is severe hypokinesis or akinesia, is a document. Another way of imaging is cardiac MR, which is a little bit complicated and sophisticated, but it's important in the diagnosis as well as the Salium technician study. Number five, intracoronary thrombus detection by coronary angio or autopsy, of course. So the combination of rise and fall of high sensitivity C-reactive protein plus one of the following five criteria gives the diagnosis of acute MI. What's the definition of angina from the beginning and stable coronary artery disease? The pain. The pain, usually we must classify it into the type, the site, the provoking factor, relieving factor, the duration of the pain, and referral site. As regard the type, it's a squeezing, dull, compressing pain. As regard the most common site is the retrosternal in the precordium. As regard the provoking factor, usually exertion or severe stress. and relieving factors is rest and or sublingual nitrates. The duration usually lasts from 30 seconds to few minutes, usually 3 to 5 minutes, and the referral site is usually the leg, lower mandible, left arm, left shoulder, or both arms, sometimes the left and the right, the axilla, and the interscapular area. So to diagnose stable angina, the pain usually is constant with the provoking factor, and usually the duration is constant. That's to say that patient comes in the morning stating that he has pain that necessitates him to stop while walking 300 meters and then taking a rest for half or 1 minute, the pain subsides and he continues to walk again. This is chronic stable angina. So what about unstable angina? What is the definition of unstable angina? Either 4 components. Angina crescendo is unstable. What is meant by angina crescendo is angina of increasing frequency and or duration and needs more than 1 sublingual nitrates to relieve the pain. This is angina crescendo. Of course, this is unstable angina. Angina at rest and angina de novo is also unstable, and angina post-acute coronary syndrome, post-heart attack by 1 month is also unstable. Let's come to the pathogenesis of atherosclerosis and the types of myocardial infarction. We all know this figure that early in childhood or adulthood, oxidized LDL goes and invades the intima, as shown in the left side of the figures. Then there is self-defense by migration of smooth muscle cells from the media to the intima to conquer this invader, which is the oxidized LDL, through several mechanisms and interleukin. This forms the plaque, and the plaque either grows gradually or progressively goes to the high side and occlude the coronary artery. So we have 2 types of plaque, the stable plaque and the unstable plaque. The stable plaque is characterized by thick cap and shoulders, small lipid core, and increased smooth muscle cells. On the other hand, the unstable plaque is usually voluminous because it comprises more the large lipid core, thin cap and ruptured shoulders, and decreased number of smooth muscle cells. So what about the types of myocardial infarction? We have type 1, type 2, and actually we have type 3, type 4, type 5. But let's speak about type 1. What does it mean, type 1? Type 1 is the atherosclerotic module, which has been explained in the previous slide. The atherosclerotic plaque tends to rupture, and rupture with erosion and ulcers or fissuring. This leads to platelet adhesion and platelet aggregation. Then the platelet aggregation is followed by platelet secretion of thrombus, and this leads to occlusion of the coronary artery, leading to acute myocardial ischemia. This is type 1. And this model from the European Society of Cardiology demonstrates well the rupture of the plaque rupture with either occlusive thrombus, occluding the whole coronary artery, and this leads to acute ischemia when it comes suddenly, and this usually translates to STEMI, ST elevation myocardial infarction, complete necrosis, or either plaque rupture with erosion with non-occlusive thrombus, and it's just occlusion by 95 or 90%, and this leads to usually non-STEMI. There is still some blood trickling inside the coronary artery, giving some blood supply to the distal myocardium. This is type 1 myocardial infarction, which is the atherosclerotic module. What about type 2 myocardial infarction? Type 2 myocardial infarction, which is cell injury and cell death due to injury. Usually it's due to imbalance between auto demand and the supply. And there are several causes of this that can lead to type 2 myocardial infarction, which is called myocardial injury. Either atherosclerotic sometimes, but it's not obstructive. For example, as in the upper figure, it shows atherosclerosis, but still it's only 80% luminal obstruction. But when there is mechanisms, either tachycardia or something, it can lead to myocardial injury. Vasospasm with normal coronary may lead to type 2 myocardial infarction, or spontaneous dissection, which leads to occlusion and obstruction of the blood supply in a normal coronary without atherosclerosis. Then comes last, the fourth, which is oxygen supply demand imbalance alone. What are the causes of oxygen supply demand mismatch? Number one is reduced myocardial perfusion, which could be due to coronary artery spasm, coronary endothelial dysfunction, coronary artery dissection, sustained bradyarrhythmias or hypotension, severe anemia, and hypoxemia. All these factors leads to reduce in myocardial perfusion and supply with oxygen. On the other hand, increased myocardial demand could be due to sustained tachyarrhythmias and severe hypertension. So this is type 1 and type 2 myocardial infarction. Type 3 myocardial infarction is this myocardial infarction that leads to death without the time to have the biomarkers. So it's sudden cardiac death. Type 4 and type 5 is related to post-PCI and post-CABG intervention. Comes next the clinical examination of the patient presenting with acute coronary syndrome. So as we stated that the main analysis is the history taking and be sure that this patient has a classic angina. The physical examination may be normal. There may be pallor, hypotension, or hypertension, or threat pulse. Sometimes maybe cardiogenic shock in the extreme if the patient is presenting with hemodynamic instability, or complication of mitral regurgitation, acute heart failure, or VSD due to septal rupture. To roll in and roll out acute coronary syndrome is very important. It's our mission here to give the rolling in and rolling out of acute coronary syndrome. So by history taking and knowing the differential diagnosis of acute coronary syndrome is very important. The differential diagnosis of acute coronary syndrome, we all know it. It's either cardiac, as myocarditis, Takotsubo, severe aortic stenosis, severe hypertension, or vascular, for example, aortic dissection, which is so serious. Number two is aortic aneurysms, which is also important, and sometimes respiratory, which is massive pulmonary embolism, spontaneous pneumothorax, and bronchitis. Other GIT as pancreatitis, GERD, or refluxoesophagitis, peptic ulcer. So to roll in and roll out, you should exclude and take a good history taking. This algorithm is very important. It's from the European Society of Cardiology. You can all check it in the ACS guidelines recently declared this September. Okay, it's integration of the clinical presentation, the ECG, as well as the troponin level. So we have now to roll in and roll out. On the left hand sided, those patients presenting with focal angina, as you can see, for example, in the root of the neck or focal in the left sided, this is less likelihood of angina. While on the other hand, the fourth from the left also, patient presenting with broad distribution of the chest pain, taking both shoulders and both arms, this is likelihood of classic angina. When integrating this with ECG on the left-sided, which is the normal ECG, there is less likelihood of this patient to have acute coronary syndrome, myocardial infarction. On the other extremity, patient presenting with ST elevation, this declares itself that this patient has classic myocardial infarction, and its most likelihood to have rolling in myocardial infarction is there. High troponin, very high troponin level from the start, taking it in the 0 hour, this also categorizes the patient in the rolling in myocardial infarction. On the other hand, taking the troponin at 0 level, then taking it very low troponin from the start, or even after 1 hour still not rising, this you can coupled with normal ECG as well as focal angina, this you can roll out myocardial infarction and you can discharge the patient and getting him to non-cardiac category or otherwise. So we have to roll in the other, on the right-sided hand, the extremes, and on the left side to roll out. Comes the in between, those patients would need to observe. Those patients, maybe there is not broad angina, the troponin is more or less weakly positive, as well as normal ECG. Those patients from the history, if they are having history suggestive of unstable angina or other cardiac condition, you should include them in the observe. And what to do for them. This is the patient suspected with non-STEMI after ruling out STEMI patients and patients hemodynamically stable. All these patients, we have the 1-hour algorithm for the diagnosis and management of the patient. This slide is very important. Also, you can appreciate here on the extreme, the very low troponin level on those patients with already suspected to have non-STEMI acute coronary syndrome. If we have from the baseline very low troponin or low troponin rise after 1 hour, you can rule out these patients if the likelihood of coronary artery disease is not high. They have less likelihood of coronary artery disease. So you can rule out this patient. On the other extremity, patient presenting with very high troponin level, either at 0 hour or 1 hour later on the second round of troponin elevation, coupled with a high likelihood of coronary artery disease, angina, you should roll them into the diagnosis of myocardial infarction. 75% of the population presenting to the emergency department will be either in the roll out or roll in. 25% of the patients will lie in the yellow zone. The yellow zone, you can't exclude 100% and you can't rule 100% of acute myocardial infarction. Those are the patients with intermediate elevation of the troponin, normal ECG, but symptoms suggestive of highly unstable angina. So in those patients, the yellow, you should take another troponin level after 3 hours. You should admit them to the ward, and usually you're going to have an echocardiography as an imaging quality to diagnose if there is loss of myocardial power or not. So those patients will go to the ward. Either you will manage them by angiography, invasive, or stress testing, or CCTA, computerized CT angio. Okay. On the left-hand side, the green zone, which is you ruled out the patients from the diagnosis of myocardial infarction. These patients will be discharged safely because the 30 days mortality usually is very low, so it's safe to discharge them. And then you can manage them with either of stress testing if there is less likelihood of unstable angina, or you can cut it short and exclude coronary artery disease by CCTA, which is CT angiography, or angiography if you have suspicion that this patient is highly unstable angina and yet not infarcted. So you can go directly with coronary angio with those patients. It depends upon the clinical presentation. On the other hand, of course, the red zone, you will proceed by admission the patient to the CCU, monitoring for 24 hours, and subsequent coronary angiography, plus or minus echocardiography. This algorithm is the clinical application of the European Society guidelines how to imply in the diagnosis after rolling out STEMI patient and those patients suspected with myocardial infarction, non-STEMI, who are hemodynamically stable. Then the 0 and 1 hour troponin tests is very important. So you should check at 0 level, troponin level. Usually there is turnaround, what does it mean turnaround? Usually the result of this 0 hour will take 1 hour to be reported to the doctor. And you should take another 1 hour, then this turnaround also, the result will be reported after 2 hours. So after 2 hours, the doctor in the emergency room should have in his hand how to deal with the patients, either in the high-risk group or the low-risk group. This figure and this algorithm is for non-STEMI patients and how to manage non-STEMI patient and direct him in the emergency room. So you have symptoms suggestive of non-STEMI and the diagnosis of non-STEMI. Then the patient coming to a hospital capable of catheter performance, coronary angio and coronary cath lab is available 24 hours over 7 days, then the patient is admitted and will be classified into either very high-risk patients or high-risk patients. Patient presenting to emergency room or non-hospital, non-PCI capable hospital, if they lie in the very high risk category mentioned by one of the criteria in the right side on the left hand, should be transferred immediately to PCI capable hospital. On the other hand, patients with high risk, that's to say one of the following criteria, as established non-STEMI diagnosis, dynamic or new, presumably new contiguous ST segment depression, or resuscitated from cardiac arrest but hemodynamically stable, GRACE score above 140, this lies if one of them lies in the high risk. And the high risk patient, if they arrive to a hospital non-PCI capable should be transferred in the first 24 hours to a PCI capable hospital and should have their early invasive diagnostic test within 24 hours. Of course, very high-risk patients should have their coronary angio and definitive management for acute coronary syndrome within 2 hours. On the other hand, patients with low risk, they could be managed by either coronary angiography or as the recommended chronic coronary syndrome patients. Let's review here rapidly the outcome of patients with acute coronary syndrome, non-STEMI. 1 year outcome in patients with non-obstructive versus obstructive coronary artery disease showed a high risk of MACE in 1 year on those with obstructive than those with non-obstructive. So the patients with non-obstructive coronary artery disease have favorable 1 year outcome as regard death or myocardial infarction than those with obstructive coronary artery disease. On the other hand, if we divide the patient of non-obstructive coronary artery disease into two categories, those with angiographically completely normal coronaries or less than 50% obstruction, you'll find no significant difference in the MACE in 1 year. Here, you will appreciate that age is important as adverse outcome after non-STEMI patient in 1 year. So, elderly have less favorable prognosis than those in the prime, those young patients. This figure also is very important and it shows the impact of non-STEMI among the population. So we have 12.7% risk of admission for myocardial infarction subsequently, 7.7% increased risk of stroke, and 53% increased risk of another acute coronary syndrome readmission during the following years. And beyond the first year, all-cause death in post-myocardial infarction survivals aged 65 years and older from 1 year after the index myocardial infarction, you'll find this is in 4 Western countries that in England and France have favorable outcome than Sweden and USA. This also shows, this figure, the impact of atrial fibrillation in patients presenting with acute coronary syndrome non-STEMI. Death, myocardial infarction, ischemic stroke, and bleeding risk are higher among patients presenting with acute coronary syndrome and AFib than those without atrial fibrillation. This is my last slide, I think, and it shows that the female, unfortunately, has unfavorable outcome after acute coronary syndrome than the whole population. And thank you very much. This is the end of my talk today.